I will be talking about indications for short fusions in adult scoliosis management. I think this is a question that we all deal with. We come to it, we have a patient that comes to us with, um, you know, multiple curves or limited pathology or extensive pathology, and how much do we really have to do to address their problem and not incur additional risk? Here are my disclosures. So I think we all know that for adult scoliosis, the surgical indications would include progressive deformity, axial pain that corresponds to their curve and degenerative changes, neuropathic pain, such as radicular symptoms that correlate with their MRI or CT. And then there's also the dynamic component, which of course is can be difficult to assess, but sometimes a CT myelogram is helpful for this. And for patients with the radicular symptoms or neurogenic pain, we also have to think about a decompression and whether all decompressed levels need to be fused. And can we avoid a fusion if we have minimally invasive decompressions, and when you have to think about including the entire curve? So in general, in the past, we've certainly understood that all levels that we'd consider unstable you'd want to fuse them as well, particularly if they're in the curved concavity for the kind of dynamic reasons. And then we want to consider fusing the entire curve, but if we decide to fuse short, we want to observe for progression and warn the patient accordingly. Certainly, I think are people that would want to think about just treating the fractional curve if that's where their symptoms are. And so certainly we can think about that. And a lot of the talk today includes patients that have fractional curves that are symptomatic. This is a patient who is kind of an interesting story. So she was a 69-year-old Asian female. She had longstanding low back pain, but worsening radicular pain. She knew about her scoliosis, but really wasn't really bothered by it. But looking at this curve, I think a lot of us would say, wow, she's got lateral aesthesia, she's got a coronal deformity and a coronal decompensation. She's got loss of lordosis. We should really do a big operation on her. And I told her about all this, and she basically went running for the door and wasn't interested in a big operation. You can see she's got significant stenosis and collapse in her concavity and up-down stenosis. She had an L4-5 injection, which greatly relieved her leg pain for 3 weeks. And these are her long films showing her mismatch and her coronal decompensation. Because her symptoms were getting worse and actually getting a little bit weakness, she kind of got forced to do something, and to I guess appease her is the best term. We did a decompression with a TLIF at L4-5 and 5-1 for her leg pain, which was the thing that was really bothering her. So at 6 weeks post-op, her leg pain was totally gone, and she came back and she said, "Well, now I want you to fix my scoliosis." So I think that is a nice way of, basically gaining trust from the patient from the standpoint of when is a big operation indicated, and what you can do and how much you can do for a patient. So these are her X-rays pre and post-op, her short fusion of her fractional curve versus extending her to include her scoliotic curve. So looking at patients who have short segment versus long segment fusions, it shouldn't be surprising to people. This is a paper out of Jefferson, and they looked at patients that had 1 to 3 level fusions versus longer fusions. And not surprisingly for anybody in this group, there was a higher revision rate for long fusion patients because they had a higher rate of pseudoarthrosis, PJK, and other issues compared to short fusions, but not surprisingly, patients with longer fusions had a lower risk of deformity progression. And so there's always that kind of what do you take on and what's appropriate for the patients. And you can see in the table that patients do reasonably well, and they actually might get better improvement with the longer surgery, a bigger surgery. But again, they may not understand this or choose to have a bigger surgery at first because of the daunting nature of some of the big surgeries we do. And again, so neurologic symptoms are oftentimes in the fractional and more degenerative curve, but it's oftentimes reasonable to consider a smaller surgery with less surgical time, less blood loss, shorter recovery, but we certainly have to consider the risk of adding on. For patients with short versus long fusion, again, there is not surprising. If you look at their Cobb angle, you're going to do much better with you if you do a longer fusion in this forest plot you see here. But if you look at the ODI, it's actually sort of a little bit favoring a long fusion, but not as dominant. And there are some studies that show that it's better for a short fusion. And again, complication rates are higher with longer and bigger surgeries, which isn't surprising to anybody here. But again, the durability of the operation is certainly something we're concerned about. I think it's really important that if you're going to do a short fusion, or as I call it, a degenerative operation, you want to maintain your deformity principles. And we want to avoid contributing to sagittal imbalance. So you want to make sure that your patients during surgery have their hips extended, not flexed. Sometimes we flex the patient to do the decompression, but you shouldn't fuse the patient in that position. You don't want to distract in the lumbar spine because that's the classic way that a Harrington rod gave us flat back. You want to make sure you restore disc height where segmental lordosis and segmental lordosis where that's indicated. And remember that that distal part of your spine is the foundation for the future. And if you can give them a good foundation, it's possible you might decrease their risk of adjacent segment disease. I think we all know, but it's important to reiterate that 2/3 of your lordosis should be at L4 to S1, which is, of course, the place that we're oftentimes operating on for these fractional curves or degenerative problems. You really want to set a foundation for future deformity surgery if they need it. You want a solid fusion in that fused segment of the spine and enough lordosis, whether you use the 2/3 lordosis at 5.1 or the gap score guidelines. And you want to think about pelvic fixation if your UIV is L3 or higher. For short fusions, we're oftentimes thinking about L3, but even in some patients with osteoporosis, you want to think about pelvic fixation for some of these as well. Here's a 83-year-old healthy Asian female, another shorter fusion than you might consider, severe low back pain, progressive scoliosis. We optimized her bone health and planned for a T4 to the pelvis fusion. I think most people would agree with a fairly extensive fusion for her. And then at the pre-op visit several days before, she said, "Do you really have to do this upper curve? It doesn't bother me." And so we kind of regrouped and we talked about the risks of progression. But we actually fused her basically in her lumbar symptomatic curve. And I cringe, as I think most of us do, every time we look at this because she's fused to the apex of her scoliosis, and this goes and the apex of her kyphosis, which goes against most deformity principles that anybody would want. But at 5 years post-op, she's actually doing fine. She has a little bit, she's gotten her hip replacement. She's got a little bit of a coronal tilt, probably from the other hip being worn out. But she still has some of that thoracic range of motion. We saved her a little bit of time on the operating table and a little bit of flexibility, and we got away with it in this case. But again, with the patient knowing full well what the options were. This is a different sort of case. She's a patient that has a very mild degenerative scoliosis, and you can see most of her collapse is at 2-3 there, narrowing at that level. An injection helped her symptoms immensely. And so we did a limited short fusion just across the symptomatic level, again, trying to correct her curve and trying to not burn any bridges. We got her to follow up for 2 or 3 years, but I've not seen her since, but she did well, at least in that short time frame. And a lot of patients in the Bay Area will seek me out if they have additional problems. So hopefully she's still doing well. This is a patient who you can see she's 63, presented with severe right thigh pain. MRI showed this large herniated disc, and you can see on the CT scan it's actually calcified. She actually been out for just a discectomy by a colleague that I thought would have recognized the scoliosis, but you can see on the sagittal image, the scoliosis is a little bit more subtle, and so if you don't get an X-ray, you might not notice this. And here she's got a significant scoliosis. It's been asymptomatic, and it's really the leg pain that bothers her. So I actually tried to talk her into a scoliosis operation because of the collapse on that side and the significance of the lateral listhesis at multiple levels. But she really just wanted me to take care of the leg pain. And she actually kind of joked that she promised me that if she needed a scoliosis operation, she'd come back to me. So we did a limited operation with the TLIF at this level to remove the calcified disc. I didn't get as much correction as I'd like to. I had the consequence of trying to put the T-lif on the concavity where her herniation was, but the T-lif cage kept spinning to the other side where it kind of was more settled. But anyway, so she did very, very well from this. But 2 years later, she's got not necessarily curve progression, but you can see she's got her degeneration has gotten a lot worse with these vacuum discs at virtually all the levels. And we went ahead and did her scoliosis operation at that point in time with nice sagittal and coronal balance here. The spine deformity study group was one of the early study groups, and they compared to patients who had had prior short segment fusions for, and then and then had longer fusions. And 30 of these patients had had short segment fusions with an average of 2.5 levels. And these were matched according to propensity scoring. And essentially, what they found is that if you'd had a prior short segment fusion, there was really no difference in the clinical outcomes with respect to functional outcomes, patient-reported outcomes, and the complication rate. So, a prior short fusion doesn't necessarily mean it would be necessarily more complicated or a more limited outcome. What about an asymptomatic deformity? So this is a patient, she's kind of interesting. She has a known scoliosis for a number of years, and at age 68, she was really not bothered by it. She was very adamant about not having me address her scoliosis. She said, I've had it all my life. And she presented basically with back and leg pain corresponding to her lumbar scoliosis. And you can see here she's got some of a mismatch. The number doesn't show up, but she's only got about 37 degrees of lordosis there. So a 20 plus degree mismatch and a pelvic tilt of 23 as she tries to compensate. And the stenosis that you can see here. And so years ago, I did a posterior spinal fusion with a decompression and T-lift just of a lumbar curve with complete resolution of her symptoms. As I mentioned, she wasn't bothered by her scoliosis. She resumed all of her desired activities. But you can see she's also quite flat. I didn't really gain much lordosis with her T-lifts. Over time, she noticed increasing imbalance and falling. She had a total knee related to the fact that she was leaning on the right side and put a lot more weight on that right side. She developed some cervical spondylosis, and we actually did ACDFs for her imbalance related to her cervical myelopathy. But over time, she's basically gotten considerably worse with her coronal imbalance, and she still doesn't have pain. And so she's like, I don't want you to operate on this. I don't have pain. So I have to convince her basically that the imbalance that she has from standing is not her neck, it's not her knee, it's really that her spine is imbalanced. So at this point in time, it's obviously a harder operation. And you can see her parameters are measured here. She's flatter, she's more decompensated. All of this makes it more difficult. She's also autofused across several segments with large osteophytes. Um, I don't know about you, but a lot of times I'll go in with these large overhanging osteophytes. I will sometimes go in on the convexity just because it's so much easier to get into. But for her, I really needed to go in the concavity on the left side on the that left side for a lateral approach. And so I sort of gave myself a time limit, and here she is on the table. And I was able to get interbody fusions from a lateral approach and basically sort of prop up that concavity there across the two levels, helping to improve her deformity. I haven't made her perfect, but you can see that the numbers are much improved. She doesn't have a mismatch anymore. Her pelvic tilt is still high, but her balance is better, and she actually is compensating a little bit backwards because she's been standing that way so long. By 6 weeks, she's only taking Tylenol and walking 2 miles a day. And at 3 years, she's doing really, really well, but now has developed some medical problems that one gets in their 70s and 80s. So in conclusion, I think shorter fusions for deformity patients may be appropriate if their symptoms are attributable just to that limited region. You will get a lower complication rate and less loss of mobility, and a lot of these patients have more rapid recovery. However, you need to warn the patient, and certainly we're aware that deformity progression may occur, generally not short term if it's in appropriately selected patients. but you want to set a foundation for the potential for future scoliosis surgery. And in general, if you set a good foundation and don't need to undo your prior work, extending your fusion does not incur higher risks than non-revision surgery. So with that, I'll conclude and accept any questions that you might have. So thank you for allowing me to present virtually.
Well, thank you for the great talk. This is, I think, just such a relevant topic for those of us that do deformity surgery. Whether it's someone who, really needs a fusion and wants a decompression, wants a shorter segment fusion, and we know from, obviously from your broad experience that, this is clearly a setup for failure. Am I going to allow this person to do something that will only be a short-term solution? So, I think we all have these patients, and, as you brought up so precisely, as long as you have that very clear communication, I think it's totally appropriate to do these. But in terms of your foresight and knowing that, maybe this person's going to be back in 1-2 years, what are some of the kind of intraoperative things that you're considering, whether it's soft tissue, some people will use some, intraoperative biologics to, reduce scarring. Is there anything like that that you think about, knowing that this is likely going to be a stage surgery?
Um, the scarring that is more concerning for me is a peridural, and so hopefully, once I've done a decompression, I don't have to come back to that area. If I do a limited decompression to try to avoid a fusion, that is a concern, but um, I will tend to, for example, if I've done a decompression or somebody else has done a decompression, I might be less likely to do a T-lift. I might do a lateral approach or an inner body or come in from the other side to avoid the scar tissue, because I certainly find that a T-lift in a prior operated case is obviously much more challenging. But I do like, since I like lateral approaches and anterior approaches, and a lot of these patients need better sagittal improvement anyhow. I do find that I can achieve that better with a lateral or anterior approach. So it isn't necessarily a deal breaker for me, but I do use that as kind of almost an excuse to avoid a redo T-lift, which although usually I get more lordosis than I did in some of those cases I saw, sometimes I can't. So it's more reliable for me to do a more open approach or more aggressive approach. But beyond that, most of the scar reducing agents that I've seen have kind of also reduced healing. And so I don't know if there's a newer agent out there that is more successful at avoiding scarring and not not causing an increased risk of infection, for example.
Yeah, I know it's something that, some products, they will try to, push that on us as spine surgeons, but, I haven't used them. I think, I haven't seen any data that's been really convincing to me, but, definitely would love to hear from anyone else in the group. Any questions from you guys?
Yeah, Serena, terrific presentation and great case examples. You've certainly taught me and convinced me that oftentimes doing less is a much better option. Is there anything that you're doing to look at the flexibility of the unfused curve? So example, if you're doing a 4-to-1 or a 3-to-1, taking care of that symptomatic fractional curve and that 11-to-4, 11-to-3 curve, do you look at the flexibility of that? And is there a threshold where you might say, that curve's just too stiff for me to really reliably do a limited fusion?
That's an interesting question. I don't actually I mean, maybe I should, but I don't actually use the stiffness of the non-fused curve as a limitation. Um, sometimes, I mean, the fractional curve can oftentimes be 3-to-1, but sometimes it's 4-to-1. And so I use that segment as an opportunity to potentially correct a little bit of the upper curve if I can, if they're flexible enough. But I think you saw at least two of my cases where the curve above, you'd be like, oh, that's really stiff. I can't get away with this. And the patients sometimes the stiffness, obviously they're trying to go on to autofuse, and unless they've got stenosis in those areas, it might kind of delay the progression because they're trying hard to build those osteophytes. That does make it harder when we go back and operate, obviously. But I think, anytime you've I think we're just used to osteotomies anyway, so the osteotomies are a little bit harder. It might or might not take more inner body correction to get the correction we want. But I haven't necessarily found that that precludes me from doing a limited fusion for patients.
Yeah, I think where I've found a couple of cases is where I might have overestimated the flexibility of a really stiff
Hmm.
curve. So from 11 to 4, say, that's really stiff. So I overcorrect 4 to 1 or 3 to 1, and then all of a sudden find that the patient isn't going to compensate as much as I had hoped. That's where I sort of think about the stiffness in terms of sometimes I'll actually undercorrect knowing how stiff it is. Whereas if somebody bends out to less than 30 degrees, I feel like I can actually correct it pretty completely.
Right. Well, that's a really good point. So I definitely try to be conscious of that, of both getting either bend films or supine films before surgery, including the non-fuse segments that I'm not going to, on the curve that I'm not going to fuse. And although usually I just get, short intraoperative films, if I have a curve above, I'll get a longer film to make sure I include that and make sure that I don't overcorrect. And now sometimes they'll fool you and they'll be balanced on the table and then they'll stand up and they won't be as balanced as you thought. But that tends to be the exception, not the rule. And I do tend to warn patients about that, they're what they look like on the table is different when they stand them up. And so, and as we all know, so they kind of get that. But it is definitely important to look at that balance on the table, however you choose to do it.
So where I take into consideration the rigidity of the mid or upper lumbar curve is depending on the OBIED classification. So if it's an OBIED 2 or BOW C, then correcting the lumbosacral fractional curve, that's the goal of the operation. And the rigidity of the mid lumbar curve doesn't really come into play. If it's the opposite, if it's an OBIED 1 or a BOW B, then if you have a rigid mid lumbar curve, and you correct the lumbosacral fractional curve, then it's going to tip them all the way over, and then it will decompensate them. Then they'll have to compensate through the thoracic spine, but I think that's a little bit more unpredictable. So I think it depends on what their coronal imbalance is with their trunk shift relative to the deformity is ultimately.
That's a nice point. Thanks.
Well, all great discussion. Going to try to keep moving through here. So next we have Dr. Bourbon again.